Good morning and welcome to this hearing in the Shekel Bio in public inquiry. This hearing begins a few days after the 8th anniversary of the death of Shekel Bio, which was marked by his families and friends. I know that the anniversary of the death is a difficult time for them. In this hearing, the inquiry will hear evidence relating to the cause of death of Shekel Bio. That will include evidence of the post-mortem examination, which is a term used in Scotland for an autopsy. Inevitably, by its nature, some of that evidence may be distressing, but I am sure that everyone will understand that it is important evidence which requires to be examined thoroughly by the inquiry. Could we now have the witness, please? Good morning, Dr. Shearer.
Good morning.
You're going to be asked some questions by Ms. Graham, whom you've met. Before that, would you say the words of the affirmation after me, please? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
that
I will tell the truth,
I will tell the truth,
the whole truth, and nothing but the truth.
and nothing but the truth.
Ms. Graham.
Good morning, Dr. Shearer.
Good morning.
You are Kerryanne Shearer.
I am, yes.
And what age are you?
I am 46.
And you are a forensic pathologist.
I am.
Now, before we go into the details of your work and your involvement with the matters we're considering today, could I explain to you that there is a blue folder in front of you on the desk? Feel free to open it up. That folder is for your use during your evidence, and you must feel free to use it or look at it or take time to consider it as you wish. And you'll see that there's a number of documents in it. I'll take you through those in a moment. And you've been given hard copies of those. But if there's anything missing from that folder that you'd like to see or you wish to refer to, please tell me. And we'll either arrange to get it as soon as we can, or we can maybe have it brought up on the screen.
Thank
So
you.
in addition, you'll see the screen in front of you. Now, sometimes when I'm referring to documents, I'll ask that they be brought up on the screen, but you'll maybe only see a paragraph or two of an individual document. You'll have the hard copy, so if there's other things on a different page, for example, you can look at those in the hard copy. And we can bring anything up on the screen that you would like.
Okay, thank you.
And it does mean that the other people in the hearing room will be able to see what's on the screen as well.
Okay.
So let's just go through some of those documents to see where we are. I think the first documents in your blue folder is probably your inquiry statement, and the number for that is SBPI 00304. And in a moment you'll see that coming up on the screen. So there we are. You'll see the front page, which is your inquiry statement, which was taken by the inquiry on the 21st of October last year and via Teams on the 13th of January this year. So it was taken over 2 sessions.
Yes.
And then on the final, it's 60 pages long. On the final page, we'll see that it was dated the 19th of April of this year. Now, on the screen version, your signature's been redacted, so no one can see that. But on your I don't know if your copy's a redacted version also, but no. So you can probably see that you've signed that on every page. Is that correct?
Yes, it is.
And if we could also look at the final paragraph, which is 183. This reads, I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry and be published on the inquiry's website.
Yes.
And you understood that when you signed?
I did, yes.
Lovely. And then moving on from your inquiry statement, because that will be available to the chair to consider in the future, but we may make some references to paragraphs as we go through your evidence. In addition, can we look at your initial post-mortem report? Now that should be PERC 01/444. And if we just move down onto the first page of that, do we see that this was issued on the 6th of May 2015? You see that at the top of the screen, but you'll have
Yes.
the hard copy. And it's in relation to Mr. Bio, and you give his details. He was pronounced dead at 09:04 on the 3rd of May 2015.
Yes.
And it was, if we go down the page, do we see that we'll come on to the cause of death and such like in due course, but we'll see the date of the autopsy was the 4th of May, so that was the day after he died.
Yes.
And the examining doctors are listed as yourself, Dr Kerryanne Shearer, and a colleague of yours. And that was Dr Ralph, is it Buhadir? Buhader, apologies. Buhader. And tell us, who was Dr Ralph Buhader?
He is the second pathologist. All of these types of cases have to be done for a corroboration point of view with two forensic pathologists, one leading the case, which was myself, and the second attending the case and corroborating everything that I do in the report.
And does that relate to the criminal justice requirement for corroboration, which
Yes.
is evidence from two potential sources?
Exactly, yes.
And so in theory, both of you could give evidence about the autopsy carried out if there was to be criminal proceedings.
Absolutely, yes.
And so on this occasion, in relation to Mr. Bio, the two doctors were yourself and Dr. And I'm not going to remember how to pronounce it. Buhader. Thank you, I'm sorry. And then let's move on to the next document. We'll be coming back to this in a moment to look through the detail. But let's look through the final post-mortem report, which should be PERC 01445. And this is headed up, you'll see on the screen, final report.
Yes.
Issued on the 18th of June 2015. So a
Yes.
number of weeks after the autopsy was carried out.
Yes.
And it is dated, sorry, I've just said the 18th of June. And if we can move down the page slightly. Again, we'll come on to the cause of death in a moment. If we can move down, please. Again, the examining doctors are listed as yourself and Dr. Buhadir.
Yes.
And then can we look at that was the final post-mortem report. Can we look at the supplementary post-mortem report? This is COPFS 05138. And this is supplementary report, and this is the 5th of November 2015. And again, we'll come on to the details of this later, but it's still by both of yourself and your colleague.
It is, yes.
And then we will look at a further supplementary report, COPFS 00040. And this is dated 3rd of October 2017. So this is 2 years after he passed away.
Yes.
And again, both yourself and Dr. Buhadir
Yes.
were involved in that. Can I start, first of all, before we go into the details of these various reports, can I ask you to help the chair understand a little bit about your own qualifications and experience?
Yes.
Before we hear your actual evidence about what you were doing. So let's look at your CV. WIT 00001. Now, is this a sort of up-to-date CV that you've provided the inquiry with, which will allow the chair to consider that in some detail?
It is,
in
yes.
the future. And if we can just scroll through, we'll see just briefly, it's from September last year, so it's reasonably up to date. Has anything changed since September last year, would you say?
I will have done more courses, more continued professional development, but everything should basically be the same.
So is this a reasonably up-to-date summary of your professional experience?
Yes.
Thank you. And it says that your current employment is as a consultant in forensic pathology. And I'm interested in what is the difference between a pathologist and a forensic pathologist?
A histopathologist, or a basic pathologist, are the medical doctors who are involved in looking at things like surgical resection. So if you went to hospital and had your gallbladder taken out, they would see that specimen and they would have that specimen processed to look at slides down the microscope and would give a report about that specimen to give the reason why it was required to be removed in the first place. And they look at various other specialties, kind of soft tissue specialties, other tumours, the gastrointestinal system will all be covered by histopathologists. And as forensic pathologists, we have to have a basic grounding in that in our initial training. But forensic pathologists specifically look at how to work out how someone has died through the tool of the autopsy or the post-mortem examination. So we are trained to look at slides down the microscope, but the main bulk of our training is to discover what causes of death are for people in all different types of situations.
So you have experience in carrying out autopsies?
Yes.
Or post-mortems?
Yes.
And working out what the cause of death is that always for possibly criminal cases?
No, we also undertake postmortems for natural and kind of non-natural deaths. So deaths in the community, for example, if someone dies and the general practitioner doesn't know why they have died, but they have died from a natural reason, a death certificate has to be issued. But if the general practitioner is not comfortable issuing a death certificate because they're not quite sure why they've died, that case will be referred into the Procurator Fiscal, and they will then instruct us to undertake a post-mortem so that we can give an accurate cause of death. We're also involved in non-natural deaths, so things like suicide. So anyone who has taken their own life will automatically have a post-mortem, a forensic post-mortem examination. So the vast majority of our workload are non-criminal cases, be it natural or be it non-natural causes of death.
And you deal with all those different types of deaths?
I do, yes.
And is part of your work making sure that what might look like a natural death, there's nothing suspicious or no interference from a third party that's brought
Absolutely.
that about?
And we will have a reasonable number of cases where it's not clear if it is suspicious. And that's why the post-mortem is being undertaken in the first place, to decide whether criminality is involved.
And your involvement comes, you mentioned, through the fiscal, the Procurator Fiscal?
Yes.
And can you just explain to people briefly how that comes about?
When cases are reported to the Procurator Fiscal, it can be from a variety of places. So it can be directly from members of the public, it can be from medical doctors, be it general practitioners, be it hospital doctors, it can be directly from the police. And the police will be involved in some shape or form and will have to put together a report for the Procurator Fiscal, who will then consider that report and consider if that's a case that requires the input of a forensic pathologist. They will then refer the case to us via the report that's been put together by police officers, in addition to an instruction sheet that will instruct us what kind of post-mortem that they want done. And by that I mean, because of the double doctor system, For example, if it is a homicide case, it will be instructed as a double doctor, where two of us will have to undertake that. But the vast majority will be referred to us just for single doctor post-mortem, so just one of us will undertake that, and those will be the cases I was speaking about, the natural deaths or the non-natural deaths like suicides. So we will get our instruction sheet from the Procurator Fiscal with some information with regards to the patient, with regards to the circumstances surrounding their death, their past medical history, and we can then take that and use that to move forward and undertake the post-mortem.
And so are you dealing with all sorts of deaths in Scotland, or is it just in a particular area of Scotland? I
work for East Federation, so we cover kind of the central belt. We cover Fife, out towards Falkirk area as well, and down towards the border. So we have a reasonably large geographical area.
And how many years have you been a consultant forensic pathologist?
12 years now.
Can you help people understand how many post-mortems or autopsies you're doing, on an annual basis, on a weekly basis?
On an annual basis, each of us, there's 6 of us in our department now, we will do between kind of 350 to 400 post-mortems each. On a weekly basis, it's vastly different. For example, this week, because I've obviously got other commitments, I'm not doing any post-mortems, but some weeks I could be doing kind of 15 or so a week. We work out of the city mortuary in town, and our usual quota is 7 cases per day. So Monday to Friday we don't do routine cases out of hours, but Monday to Friday there'll be 7 cases that 2 of us will be down doing, so one doing 4, one doing 3. And then anything suspicious or double doctor requiring will be done out with that, normally in the afternoons or in the weekends.
So you can be asked to work at the weekends as well?
Yes,
if something
yes.
suspicious arises?
We're on call 24/7, so there's always a forensic pathologist on call 7 days a week, 24 hours a day.
So you've built up, it would sound like, a lot of experience in relation to carrying out autopsies.
Yes.
And can you help people understand when you're doing maybe a suspicious death or an unexplained death where there's a double doctor, as you say, can you explain to people what you're doing as a pathologist? You've talked about trying to work out the cause of death, but what are you looking for? What's the importance of your role in that?
What we do initially is a very detailed external examination. So we will look at every part of the body very, very carefully, documenting anything that we're seeing. So we'll begin with a general examination, so looking at things like height and weight, build, hair colour, eye colour, so anything that potentially gives us an idea of who the person is. Things like tattoos and scars we will look for again, because that can be an indicator of who the patient may be. And after that we will look in great detail for any injuries that are present externally, down to tiny little things that might be a 0.1 of a centimetre. Everything that's on the body will be documented. And following that we will then look internally, so we will look at all of the organs, all of the rib cage inside the head, and what we're basically looking for is a reason for their death, i.e. is it natural? Do they have, for example, heart disease? Do they have pneumonia? Do they have anything that we can explain why they have died suddenly? But we're also looking for internal injuries, so do they have any internal injuries? For example, have they broken some bones, have broken ribs, have any of those pierced the lung that could have caused a collapsed lung? If it is a potential homicide, if it's maybe been a stabbing or a shooting or anything, then we document everything, every injury internally that has happened because of what's happened during that potential assault. We will also take a variety of samples from the body, both externally and internally. Some of the samples specifically for and under the instruction of the Procurator Fiscal. So, for example, swabs, maybe if you have a potential assailant and they have scratched the perpetrator, we would take nail swabs, which would be under the instruction of the Fiscal, that would be then given to the police as productions. But we also take a number of samples for us for the completion of our report. And that's why you have initially a provisional report and you have a final report, because there's lots of investigations we take that we then require a reasonable amount of time to get that information back. So things like toxicology, we'll take samples of ideally blood, urine, and we will send that off for a detailed toxicological examination, and that may form part of our report, it may form part of our cause of death. Things like histology. Histology is looking at something down the microscope, so we will take some very, very small sections of, say, a small section of heart that will be processed by our lab and put on a slide and stained for us, so we can have a look at the actual structure of the heart to make sure there's no damage that may be related to the cause of death. And we do that with all of the lungs as standard, all of the organs as standard with all of our post-mortems. And we've also have access to things like neuropathology, virology, bacteriology. So there's lots and lots and lots of different investigations that we undertake that will all form the basis of our conclusions and the basis of our cause of death. So it is a very detailed procedure. I mean, some post-mortems can take 12, 13 hours, sometimes longer, to be fair, depending on what you're finding and how much detail and how many injuries you're finding at the time.
But there's a lot in that answer, and we'll come back to much of this in more detail, specifically in relation to Mr. Bio. But can I just touch on a couple of things that you said there? You talked about looking externally and internally, as well as looking internally for things, I think you mentioned, like heart disease. Would you also be looking for signs of infection or inflammation or that type of thing?
Absolutely. Any disease process that potentially may have played a role in death. To be fair, not even necessarily having had to play a role in death, any disease process we would be looking for.
And you've talked about taking samples. Is this something, you mentioned earlier that a histopathologist would be taking samples and testing tissue and that type of thing. You said you had a grounding in that. So is that the experience you have in that role, does that follow through with this type of samples you're taking?
Absolutely. When in our initial training, I did four years training in histopathology before I moved into forensic pathology. So my qualification allows me to look at my own tissue samples. And I take tissue samples on all of my post-mortem cases. So I mean, I've saw thousands over the years. So I have looked at a lot of tissue down the microscope.
And you've talked about sending off samples and swabs and tissue samples. You've talked about some of the areas that are investigated after you've carried out the autopsy. Toxicology, histology. Are these sent externally to other specialists?
They are. Our toxicology is sent to a lab in Glasgow. So they have toxicologists that will process those samples and give us results. But the interpretation of those results is really up to us and how we incorporate that into our post-mortem report. But we will they will look for the specific drugs, and we will get a report detailing what they have or have not found.
And once they've prepared those or carried out that investigation, would they prepare a report and send that back to you for you to consider?
Yes.
And then you say that's part of your assessment when you consider cause of death?
Yes.
And so the final assessment of cause of death, is that very much dependent on all of these investigations and the results of those investigations?
Exactly, yes.
And you mentioned histology. Tell us what that is.
So what happens is you take tiny pieces of tissue of various organs, and the lab take tiny slices, kind of very kind of microtome, kind of millimetre thick slices of that, and will place it onto a glass slide. They will then use special stains to stain that so that we can look at that under the microscope. So you see the cellular detail of organs. So for example, in the heart, the heart's a muscle. It's made up of muscle cells. And I can look at sections of the heart down the microscope and look at those muscle cells, look if there's any damage to them, either acutely or chronically, if there's any scarring or anything like that, which can maybe give me an idea of a disease process that may be happening in the patient and potentially a cause of death.
So is that what you were mentioning earlier, where if someone dies suddenly, you're looking at these samples to say, was it a heart attack, to use a layman's term?
Exactly.
Or was it a cardiac arrest?
Yeah. So in the vast majority of our routine cases, we will take a wide sampling, or we will widely sample the heart, because you don't necessarily have to see changes grossly when you're holding the heart in your hand. You can see changes microscopically that are not necessarily apparent, so it's best practice to widely sample to make sure that you're not missing anything.
And you've used the word gross or grossly just a second ago, and microscopically. Can you explain to people who are listening to your evidence what that distinction is?
Grossly is naked eye. It's having something in your hand and being able to look at it. Microscopically is having to do a series of things to the tissue to be able to see the microscopic detail, so the tiny detail that you would require a microscope to see.
And as part of your role, and looking at everything, are you doing both those things, looking visually at things to see if there's any differences, and also looking microscopically and considering the results of the investigation?
Yes.
Thank you. And can I ask you about post-mortems generally? People might be interested in the sort of time scale involved in the instruction of a post-mortem. You've talked about the fiscal being involved. Maybe there's been something raised by a member of the public or the police. The fiscal's involved in the instructor post-mortem. What about the sort of time scale? Obviously, you're a busy pathologist. You're doing a lot of work on a daily basis. How quickly would a post-mortem generally be carried out if there's a suspicious death?
In a suspicious death, as quickly as we possibly can, hence why we're on call 24/7 and we do cases at the weekend. So in the vast majority of cases, if we get a call, let's say if I got a call on a Saturday morning, if there was a possibility, which doesn't often happen now because the processing of scenes tends to take a bit longer than it did maybe 10 years ago. But if there was a possibility of the body being able to be transferred to the mortuary and us being able to set up, because we need to organise things like photographers who need to come and police officers for productions, and so if we could do that, we would do that post-mortem on the Saturday afternoon. 9 times out of 10 it probably would be the Sunday, but we would try and do that post-mortem as quickly as possible, and that tends to what happen in all suspicious cases. It would rarely wait for a few days. We tend to it happens as quickly as possible. The other thing is we obviously do have another workload. We have routine cases, so we have other things to do Monday to Friday. So often you want to get a case done as quickly as possible as well, because you don't want it to be delayed or have any knock-on effect to your routine work during the week. So if it's a weekend case, 9 times out of 10 it will be done on the weekend. If we're called on the Sunday, it would probably be the Monday. But all of these cases tend to get done as quickly as possible.
And would that be the position even in 2015?
Yes, yeah.
Called on the Sunday, probably done on the Monday.
To be fair, even more so. Nowadays it does take longer to process scenes, and so it takes longer to get the body from the locus to the mortuary. So that can have an inbuilt delay of a day or so, whereas back in 2015 I don't think that was the case. So I think the vast majority of cases we would have done as quickly as possible, either same day or following day.
And when you use the phrase processing the scene, what is it you mean?
When a body is found at a locus, be it, say if it's in a house, and there's a potentially suspicious circumstances, there's a lot that has to happen at that scene in terms of making sure that all evidence is gathered. So forensic scientists, forensic biologists, police photographers, and sometimes ourselves will go out to scenes. So there's a lot of things to do at scenes before a body can actually be removed. And in years gone by, certainly when I first qualified, it tended to, things happened overnight, so this sort of work was done overnight. But now, kind of reasonably frequently, I think, from various reasons that I'm not privy to, things tend to get stopped and halted overnight, so scenes are just closed, and the investigation is kind of taken up the next morning when I think people have more of an idea about what's going on. So there's that kind of inbuilt delay of the scene actually being processed. So that puts a delay to the post-mortem happening.
And if the person did not die at a scene or at a locus but was taken to hospital, does that have an impact on the time frame?
Yeah, because that would be much quicker. Because the body would be able to be taken to the mortuary much quicker, because they're coming from one mortuary to another, and there will be a locus probably, or there will be a locus, but that locus can be dealt with separately because the body is not in the locus, so that would tend to remove the inbuilt delay if they were taken to a hospital, yes.
Does that then allow the post-mortem to take place more quickly?
Yes.
And why would it benefit the investigation to avoid delay in the post-mortem? What would the benefit be?
Well, from my point of view, it's much better to do a post-mortem as quickly as possible, because the minute someone dies, they do begin to decompose, different rates depending on the kind of climate or circumstances. But from my point of view, I would much prefer to do the post-mortem, to do the external examination, the internal examination, and more specifically, get my samples. Because when I was talking about histology, so little bits of tissue, the tissue begins to break down very quickly, and if the body's left for a reasonable period of time, it can actually alter what I can see down the microscope. So we would always prefer to do the post-mortem as quickly as possible, because it may affect how we are able to describe things. It may affect the information that we can give about cause of death if the body has begun to decompose, and it affects our sampling.
Is there anything you can do to preserve the body pending the post-mortem?
I mean, all bodies will be refrigerated. Right. Hopefully as quickly as possible, and we'll be coming from one refrigeration situation in a hospital to the city mortuary, so that would be automatic, but that doesn't completely stop a body decomposing. It doesn't, unless you freeze a body. You're still going to get a degree of breakdown even if they are refrigerated, and we cannot freeze bodies without very good reason, because that again, when you freeze a body and the body has to be reheated, that will affect what we're seeing grossly. It will affect what we're seeing histologically, and we may fail to get toxicology because of that. So that's not an option in the short term. And the only bodies that tend to be frozen are after the post-mortem, if there's an issue with the release of the body, or if there's no family to claim the body may be frozen to reduce breakdown. But at that point, from our point of view, it doesn't matter, because we have all of the information we need to be able to give a cause of death and give family as much information as possible.
What difference does it make to that process if the body has not initially been put in a fridge or a refrigerator?
You mean?
So you talked about bodies being refrigerated,
mm-hmm.
And that helps to avoid some of the elements of decomposition? What if the body is not initially put in a refrigerator or kept in refrigerated circumstances?
The body, well, depending on what circumstances they are kept in, or what, people will decompose more quickly if they're in higher temperatures, if they're fully clothed, if they have any concurrent infections of the body before they die that increases their core body temperature. So there are all sorts of situations that can increase decomposition. But if you don't refrigerate the body as opposed to refrigerating the body reasonably quickly, then they will begin to decompose.
Can I ask you in general about the post-mortem? Who would normally attend a double doctor post-mortem?
There's normally quite a long list. Back in 2015, pre-COVID, it has changed since then, with people not being able to come into the PM room and all of the kind of rules and regulations, and it hasn't really reverted back. But apologies, back in 2015, we would have be myself and my second doctor. We would have a mortuary technician in the PM room. We normally would have 2 police officers who would be doing productions, so they would take any productions that we would have to put them in bags and write the relevant information on that. And we would have a procurator fiscal present. Often we would have the crime scene manager, whoever was managing the scene, if they were able to, or certainly the SIO, the senior investigating officer. So there would be a few kind of senior police officers as standard. So it's quite a busy area, although the vast majority of times most of those personnel would be in the viewing gallery and not actually in the post-mortem room with us. And I think, obviously in this case, it was PERC were involved, so it was 2 officers from PERC who were doing productions from what I can remember, rather than police officers.
So, in relation to Mr. Bio, do you actually remember who was at the post-mortem?
Yeah, well, not names, but
No.
certainly people, kind of procurator fiscal, 2 PERC officers, and a photographer, myself, Dr Behader, and one of our mortuary technicians.
And what does the mortuary technician do?
They're there to help us, with whatever we need with the body. So getting the body from trolley onto the post-mortem table, helping us move the body if we have to manoeuvre during the post-mortem, kind of turn the body over. They also tend to open the head, and during the post-mortem we look externally at the scalp, but we always open up the scalp to look underneath, and then the skull will be taken off for the brain to be taken out. And the mortuary technicians are trained to do that, so they will normally do that for us, and any other detailed procedure that we require them to do depending on what we're finding at the post-mortem.
Tell us about how the body is identified prior to you conducting the post-mortem.
There are a variety of ways of doing this, which has changed greatly since COVID also. But back in 2015, the standard way would be that we would have relatives or family or someone who knew the deceased in life would come to the city mortuary. We have a viewing gallery, so we have a little room, and behind glass there's normally the trolley with the deceased, who will be fully covered kind of up to the neck area, so it's really just their face that's exposed, and the family members or friends will attend, and I will normally have a conversation with them beforehand and just explain who I am and what we're going to do, and how the identification is going to take place. And then I would take them through and let them see their family member, and I have to ask them to let me know that this is definitely their family member, and that will all be kind of documented on on paper exactly who they are and who we are and anybody else involved. So that's one of the ways of doing it. I mean, there are several ways that we can do identifications. There are occasions where a deceased may not be viewable. It may not be reasonable to expect a family or member or friend to see them if they're maybe very decomposed or if they have lots of injuries. In which case I would suggest to the fiscal that we don't do it that way and we find an alternative way, whether that is by DNA identification or dental identification. That's a discussion that I normally have with the Procurator Fiscal. We have had cases of identification where people have been known to the police, so they've been able to identify to us. But the vast majority of cases now, post-COVID, are being done by DNA. So there are various methods of identification, and the identification is instructed by the Procurator Fiscal with a discussion with us as to the best way to do it if we are uncomfortable for people to see the actual body. But it is something that is ultimately, we're told how it has to be undertaken by the Procurator Fiscal.
How common is it or in 2015, how common was it for family members to be involved in the identification of the body before the post-mortem?
Reasonably common. Reasonably common. Probably the commonest way to do identification, maybe because obviously these cases tend to be homicide cases, so family can be very upset. So it was often not immediate family, maybe kind of aunts or kind of someone out with the family, because the immediate family would have been obviously far too upset to come and have to do that. But some sort of identification by friends or family, it was the commonest way for it to be done, certainly as far as I can remember back then.
And if the family were not involved and the person was capable of being viewed by a family or friend member, is that something that you would have raised or questioned with the fiscal?
No. It's not. Again, it's not my remit. It's not my job to decide how this is done. We can have a discussion, but ultimately how it's done is decided by the Procurator Fiscal. So I can't remember at the time having any discussion as to why it was being done any differently.
And you don't remember having any discussion about that. Was there any reason why you would have raised that at the time?
I don't remember having any discussion. It's not something I would document. I was probably, my thoughts would be that maybe family were too upset to be involved, because we have had that on previous occasions for very good reasons. So I'm assuming my thought process was probably that at the time, that family were far too upset to be involved. But again, I can't remember having a specific discussion about it at the time.
Was anything ever said to you by the police, for example, about whether the family wanted to view or wanted to make arrangements to view?
The viewing tends to happen after the post-mortem examination. The identification is not a viewing per se, because it's very, very brief. The family can't go anywhere near the body, and it is really solely for the purpose of identification. So viewings do happen, and we do get a lot of requests for viewings for kind of before the post-mortem examination, and again, it's up to the fiscal to allow that. It's not, we can't give the okay for that. But I know lots of viewings do take place after the post-mortem examination.
So there might be an identification process, a brief identification prior to the post-mortem.
Yes.
But then a viewing separately.
The viewings tend to be, because the family want to spend time with their loved one, and that's not really possible, where there's no pressure, but obviously the post-mortem is about to take place, and we try and give the family as much time as possible, but it certainly wouldn't be as relaxed as it would be if they were coming in after the post-mortem, where they would be given as much time as they need, and it's a kind of a much better, more relaxed circumstance. There's not two pathologists standing there and normally two police officers standing there and a whole lot of kind of people standing outside waiting, it would be much more relaxed, where the mortuary staff would just take them into the viewing room and leave them for however long that they wanted to stay.
And that's possible because by then the post-mortem's been taking place.
Yes.
Tell us about your awareness in 2015 of cultural sensitivities and that type of thing when you're preparing for a post-mortem.
We are asked a lot if there are different cultures involved, and there are obviously specific religions that do require bodies to be returned as quickly as possible, kind of within 24 hours. So we come up, or we're asked about this reasonably frequently, and as much as we can, we will try and help. We will try and expedite the post-mortem, do it much more quickly. These tend to be routine cases, because in suspicious cases they are being done as quick as we possibly can. In routine cases that we do on a daily basis, our waiting times can be anything from a week to 3 weeks after the person has died, depending on how busy we are. So if we do, it comes via the Procurator Fiscal, that with the family circumstance and asking if there's a possibility of doing things quicker, we will try and do that as much as we possibly can.
Who would raise any cultural or religious sensitivities with you, and when would they do that?
It would normally come from the Procurator Fiscal, because we don't have any, we don't speak to families, we don't have any input with families or interaction with families, unless after the post-mortem's been done and the report's gone out, family members may ask to speak to us, and we'll have a family meeting, and we do that reasonably frequently where they've got questions about the post-mortem. But we don't, up until then, we don't have any direct contact with family. All the information that we get comes via the Procurator Fiscal. So we will often, with our routine cases, we will often get an email just explaining the situation and asking if there's any way of this being expedited. And 9 times out of 10, that's not a problem. All of us will quite happily do the case quicker in order to aid the body release to get back to family as quickly as possible.
So from what you're saying, normally the information, if there is information about any cultural or religious sensitivities, that would come to you via the Procurator Fiscal themselves?
Yes, yes.
Are there any cases where the police would provide you with that information, or is it generally the Fiscal?
There may be, the police provide the police report, so there may be information in the police report about the person being Muslim or some other religious, but I think unless I wouldn't, if I had that in a report without the Procurator Fiscal getting in contact, I wouldn't expedite that myself at that point. I would wait for the Procurator Fiscal to get in touch with families' wishes and then move it from there.
So would your expectation be that information regarding those matters would come to you direct from the Fiscal?
Yes.
And if that information came from the Fiscal, you would then act upon that?
Yes.
Have you, or in 2015, did you have prior experience of performing autopsies on the body of a Muslim person?
Yes, I'm sure I have done over the years a number of cases, yes.
And were there any particular issues that you were aware of from that previous experience?
I think often we're made aware that families don't want a post-mortem being undertaken, and we completely understand that. But again, it's out with my control of that being undertaken. When a case for particular reasons is referred to the Procurator Fiscal, a full post-mortem examination is legally mandatory, and it's very difficult for them for that not to happen. So we are aware of kind of families' wishes. We often get information to say the family do not want a post-mortem, and if there's any way that we can avoid it but that would normally be in a natural death, where we may be able to do a view and grant examination. That is a procedure that we have where we do an external examination only to make sure there's no injuries that we would be worried about. We would have to have a significant amount of clinical information to say that a person had a specific past medical history that may explain why they've died suddenly. And in that, it tends to be in older people as well. It tends to be in elderly people. In that sort of situation, if the family really don't want to have a post-mortem, and to be fair, that's not always on religious reasons. We see that in a lot of cases of families who just don't want a post-mortem, which is completely fine. In those sorts of cases, we will try and do a view and grant examination so there's no cutting of the body. But that doesn't exist for potentially suspicious cases. It's not possible. Those types of cases have to have a full post-mortem, and I can't do anything about that. But I have to take instruction from the Procurator Fiscal and undertake those post-mortems.
Thank you. And from your prior experience, are you aware of sensitivities? You've talked about the avoiding delay and some religions wanting to deal with the body quickly. Are you aware of any sensitivities regarding taking hair samples at all?
I think there are. I wasn't aware of this until I did some reading. I think there are some religions where it does go against their religion to have that undertaken as well. And I know it was discussed in this case. But again, if it's very, very important with regards to cause of death or getting as much information as possible, then it's something that we can't not undertake, and we can't avoid doing it if it potentially is going to be helpful with regards to the amount of the information that we want to give at the end of the post-mortem. Because there was a discussion in Mr. Bayo's case with looking at hair for toxicology, and what we would do there is if someone is taking drugs chronically, so over a period of time, the way the body processes them, it also grows in the hair. So we can take a hair sample, and the hair grows at roughly 1 centimetre a month. So if we got a few centimetres of hair and it showed specific drugs in those centimetres, it can tell us that drug's been taken over a period of a few months. I mean, occasionally I've done it on people with 10, 12 centimetres of hair if they have longer hair. That's something I do reasonably frequently to look at chronicity. So that was discussed at the time, but his hair was very, very short, so it wasn't done. If the hair had been longer, we would have had to look at certainly doing that, and that would have been under discussion with the Procurator Fiscal to make sure everyone was happy that was happening. But it wasn't, we weren't able to do it in this case for those reasons. There are other hair samples that can be taken at post-mortem. As police productions normally, so head hair can be plucked, pubic hair can be plucked, and the main reason for that is for comparison sakes. If police are finding hair at a locus, they can do a comparison, but those are purely police productions. They have nothing to do with pathology. And there are a number of samples that we take at post-mortem that we take under instruction of the Procurator Fiscal with the police, that are handed directly to the police. We will sign the bags because we have taken them, but we will never see those samples again. We don't process them in our labs. I don't interpret any results from them. They go to a police lab for interpretation. So that would be another side to hair being taken that I potentially might take just because I'm the person at the PM table, but it's not samples that we would take for our purposes.
I'd like to move on and look at your initial post-mortem report. So let's have that on the screen, please. PERC 01444. Now, we looked at this very briefly just at the beginning. You've got the hard copy. And we'll see this is issued on the 6th of May. And if we move down the page, you'll see it's pronounced dead on the 3rd of May at 9:04. The date of the autopsy was the 4th of May, the day after. And then here your report's dated the 6th. And the cause of death here is unascertained pending further investigations. Now, you've talked about doing this initial report. And can you just, in general, explain to us why this is issued saying 1A, cause of death, unascertained pending further investigations?
So this is the cause of death that's given immediately after the post-mortem with what I have, the information I have that I've deemed from the post-mortem in the external and internal examination. And in this case, there was no obvious cause of death at the time of the post-mortem, hence why it's unascertained pending investigations, because I've taken various investigations during the post-mortem that I will then look at for the final cause of death when I have all of the information.
For the purposes of a comparison, what would, in your view, be an obvious cause of death?
If we stick with potentially suspicious cases, if someone has been stabbed 7 times, and one of those stab wounds I have at the post-mortem I have discovered has gone directly through the heart. It's bled into the sac that surrounds the heart and also bled into the lung cavity. The cause of death there would be stab wound of chest or stab wound of heart. So I would be able to give a specific cause of death at the time of the post-mortem, because all of the other investigations that I do, I would still do histology, I would still do toxicology, but none of them are going to add a huge amount, because at the end of the day the person would have died because they've been stabbed in the heart, and I can categorically confirm that at the time of the post-mortem.
So in relation to Mr. Bile, it was unascertained and pending further investigations. And so was this the initial report then allowed you to have those investigations carried out and the samples and the swabs sent to other specialists to do reports?
Yes, yes.
And the benefit to people of having this initial report issued, what does that then allow?
It allows the police and the fiscal to move forward with their investigations. It also allows, if there's a defence post-mortem, so in potentially suspicious cases, there will be another pathologist will come in, and to be fair, back in 2015, defence post-mortems tended to be done with a separate post-mortem being undertaken, but it's always very, very helpful for that defence pathologist to have my report or a report in front of them to see exactly what's been found at the post-mortem, because the post-mortem does disrupt the body, and also, as we spoke about previously, albeit the person is refrigerated, the body still can decompose, still can begin to break down. So what they see when they come to view the body may be slightly altered to what I saw when I had the body at the very beginning, when it was very, very fresh. So it's really, really helpful for the defence pathologist to have the primary pathologist's report to look at before they undertake their post-mortem, if indeed now the things have changed and defence pathologists don't tend to do a second post-mortem now. It's all done as a paper exercise with our report and with photos, and also it means that if they have our provisional report and they have the photos from the post-mortem, and there may be something that they're thinking that we've potentially missed, they can then decide to go to the body and have a look at the body themselves. But if they think all the information is there from what we've provided, then it stops a second post-mortem having to be undertaken, which is more destruction of the body, and also stops the deceased from being released to the family for a longer period. So it means the proceedings can be finished slightly earlier, which means the body can be released and the family can move on with the funeral and things. So it's a much better way to do things.
Mm. So in this initial post-mortem report, or provisional as you've coined it. What information is put in this report by you?
Well, I will put in, obviously the front sheet is the details.
We'll come through that in a minute, but just in general.
I tend to put in the background circumstances, I'll put in information that I have thus far been made available to me, which will normally be by police and in this case by PERC. So any information that they've given me, normally we have a briefing report, I will tend to include that. So any information that I have that I think is important beforehand, before the post-mortem examination was undertaken, will be put in the background circumstances, and the actual post-mortem report will be kind of what I said previously as to what I do in every post-mortem: a thorough external examination, a thorough internal examination, and then there'll be a list of investigations that I'm going to undertake and a list of samples that I've been asked to take for the Procurator Fiscal. A very brief conclusion, which will normally just be a line, because I don't have a conclusion at that point, and whatever my cause of death is initially.
And before we move away from this page, we see medical cause of death is listed as 1A, unascertained. Can you explain to us what it means that it's number 1A and it's unascertained? Can you give us a little bit of information about the numerical system?
So this is how deaths are certified in Scotland. The death certificate that has to be issued on every person who dies has to have a death certificate issued in order for the family to register the death and for the person to then have a funeral. And on that death certificate there are kind of numbers and letters: 1A, 1B, 1C, 1D, and then a part 2. And the 1A is the primary cause of death. It's for example, when I was talking about the stab wound, 1A would be stab wound of heart or stab wound of chest. If you had someone in a natural disease that had died of a heart attack, say, and that's what I was finding at post-mortem, my 1A would be myocardial infarct, which is the medical term for a heart attack, and 1B would be coronary artery disease or coronary artery atheroma. And the reason for that is the 1B is what leads to the 1A. So if you have narrowing or furring of your arteries, you get blockage, oxygen doesn't get to the heart, and you have a heart attack. So it's the coronary artery disease that are causing the heart attack, so 1A, 1B. So this, the vast majority of cases will just be a 1A, but you can get, for example, if someone dies of a pulmonary embolism, that's a clot in the lung. I will find that at post-mortem. I will also look for clots in the legs, deep vein thrombosis, because that's the commonest place that the clots will come from. That will give me a 1A of pulmonary thromboembolism and a 1B of deep vein thrombosis, because the clots have originated in the legs, they've gone up to the lungs, they've blocked the lungs, and they've had the clot in the lungs, and that's ultimately what's killed them. If they, for example, had 2 weeks before broken their leg and had been unable to walk, so had been quite immobile, that's a huge risk factor for getting a clot in your leg. And if I was able to, I'm able to say cause and effect, so that would be 1A, pulmonary thromboembolism, 1B, deep vein thrombosis, 1C, fractured leg, lower leg, or whatever it was. If that fracture was due to a fall, that would go into 1D. If that fracture was due to surgery, it would. So it's kind of this causes this, causes this, causes this, is the kind of list you get from 1A to wherever it goes. And then under part 2, you have other factors that may have played a role in the death but are not directly related. So things like, I was talking about the heart disease. If you're diabetic, you're more prone to developing heart disease. You've got a much higher risk of developing heart disease. So although the diabetes is not directly led to a heart attack, it has indirectly, because it's given you a reason or a risk factor, if you like. It's things like if you've got lung cancer in the 1A and you're a smoker, it'll go under part 2. It's things like that. So one is the 1A to 1D are direct kind of cause and effect, whereas the part 2 tends to be factors that could have played a role but are not directly related.
So the smoking at part 2 doesn't smoking a cigarette doesn't cause you to develop or to kill you, but it would be an underlying risk
It's
factor.
a risk factor, exactly.
Right.
Yeah.
Thank you. Can I move down this page, please, onto page 2? Thank you. So here, this is your provisional or initial post-mortem, and I want to go through this in some detail with you, if I may. And we say at the beginning, you've detailed who you are and the instructions you've received, and then you talk about the identification of Mr. Bio and the people who were there to identify him. And we've already discussed the fact these are not family members. And one of them was Peter Grady, Detective Constable from MIT, or MIT as the police call them. And then both scene managers dealing with the deceased at Victoria Hospital. And that was DC Grady and John Ferguson, who was from Perk. So they were both there and assisted you with the identification.
Yes.
And then we see background history, and if we could look at that. And here, if we just stop there for the moment, please, we see a number of paragraphs that we'll look through, but these are these your notes about the circumstances that caused Mr. Bio to be to require a post-mortem?
Yeah, taken from the information that's been provided to me. I've kind of summarised what I thought were the kind of important points.
And where was that information coming from to you?
From a briefing paper that was given to me by one of the members of PERC.
Right. And so this is paperwork that you're given in advance of the post-mortem?
Yes, I got that prior to the post-mortem.
Prior to the post-mortem, had you had a chance to consider that information?
Yes. Mm-hmm.
And then we see here also in bold, the general practice notes are awaited, the hospital notes are awaited.
Yes.
What does that mean?
It means that they have been asked for, as in I have asked for them to be got, but I haven't actually seen them prior to the post-mortem examination because they've not been able to get them prior to the post-mortem examination, which is a fairly frequent occurrence.
And when you say fairly frequent, does it cause you, what issues does it cause you if they're not available?
It doesn't cause me any, if it caused me any issues, I wouldn't do the post-mortem. Right. I have had cases in the past where the medical notes specifically haven't been made available, and I have not undertaken the post-mortem until they've been given to me, which can delay the post-mortem by a day or so. There are some cases where categorically I would not undertake the post-mortem examination if I don't have these notes. Those mainly are cases where people have undergone major surgery after having been assaulted or stabbed. And I want to know categorically what a surgeon has done, because I'm going to have to differentiate potentially what they've done with what the assailant may have done. So I need that information prior to the post-mortem examination. So that's one of the main reasons I would not continue to do the post-mortem if I didn't have that information. In this case, I didn't think that was required. I had a reasonable amount of information given to me, and I didn't think it was going to alter what I was going to do at the time of the post-mortem, and that's often what will happen. I will always get the notes and I will have a really good read of them afterwards and make sure there's nothing that I've missed, but if I needed to stop, I would have stopped.
Can we briefly have a look at your inquiry statement? We will come back to your report in a moment, but this is SBPI 00304, and I'd like to look at paragraphs 6 to 8, please. And this is headed up information provided regarding the circumstances of death, and you talk about receiving a call and the fiscal, and there'll be a discussion. You see that section of your statement? And
Yeah.
then you're asked at 7 about some notes. The chair can read this in due course. And if we can look at this, actually, could we go back up to 6 just for the moment? At the very end, the final paragraph, the final sentence, sorry, in paragraph 6, it says, I remember it was a very dynamic situation and there was insistence for the post-mortem to be done as quickly as possible. I wonder if you could explain a little bit more about that for the chair.
I remember at the time, because I took the phone call on the Sunday, and already there was a lot of kind of media interest, there was a lot of kind of information kind of already out there. So, and there was obviously questions because there had been police involvement as well. So I do remember there being a reasonable amount of stress surrounding that, and also a reasonable amount of pressure to get the post-mortem done as quickly as possible. But bearing in mind these sorts of post-mortems I would have done as quickly as possible anyway. But I do remember, because of the circumstances surrounding the case, there was pressure that I have never felt before, I suppose. But again, doesn't change the fact that it would have been done as quickly as possible anyway, because these types of cases tend to be.
And you use the word insistence there, you've talked about pressure. Where was that coming from? Do you remember who that was from?
I honestly can't remember. I remember the feelings at the time, but the kind of situation was so kind of quick and unfolding. I can't remember exactly where it was coming from, or if it was just generally the whole kind of atmosphere.
Right. And when you talk about the atmosphere, can you remember the people that were contributing to that atmosphere, or the nature of their role?
I mean, specifically, no, I can't remember exactly who. I mean, I spoke to the Procurator Fiscal on the Sunday, because they would have been the person that would have phoned me. I can't remember if I spoken to anyone from PERC on Sunday or not. I didn't make a note of that. I could have done, but I honestly can't remember.
Did you have any conversations with individual officers?
Again, on the Sunday, I don't know. I don't think so. It wouldn't be common for me. I mean, I occasionally, on cases, if I need to go to scenes, I will speak to the SIO because I can get a better idea of timings, and it means I'm not hanging around for ages. So I honestly can't remember if I did or didn't speak to anybody. I know on the Sunday we had decided that we were doing the post-mortem on the Monday, which is what I would have done anyway. It couldn't have been the Monday morning, because we already have routine cases on the Monday morning, and we cannot cancel routine cases, because that would have a knock-on effect for several families who are obviously waiting for loved ones to have funerals. So very, very quickly the post-mortem was organised for the Monday afternoon, which, to be fair, is what would have normally happened. I just remember at the time that there was a lot of stress involved with that.
Was there any conversation with DC Grady?
I honestly cannot remember if I spoke to anybody specifically. I didn't document anything, but I wouldn't have done, to be fair. I wouldn't have written anything like that down to be put in my report if I had spoken to them. If it was about the circumstances of setting up the post-mortem, but I honestly cannot remember.
Right. Can we look at paragraph 11? You mentioned earlier having a briefing prior to the post-mortem. Written information was provided. There isn't a document reference in that paragraph, but could I ask you to look at WIT 00003, please, and just confirm if this is the briefing note that you were provided with. And we can maybe bring that up on the screen. Does this look familiar?
Is this in?
You've not got a hard copy.
Oh, okay,
sorry, you'll
sorry.
have to look at the screen. Sorry. So if we could just scroll up very slowly and let you see that. If you'd prefer a hard copy, we could arrange that at the next break.
Okay.
But if we just scroll through and let you have a look at that and see if it looks familiar to you.
I think the best way to correlate is to look at the language and what's in that and what's in the background circumstances of my provisional report. And I think it is very, very similar, because I very much take what's there. I don't tend to change the language. I tend to keep the sentences very specific to what's in the information that's provided to me. And I think it is very, very similar. So I think I have taken the information directly from here.
Thank you. Would it help if we do provide you with a hard copy of this?
Possibly.
Right. Well, we can do that at the break. But thank you. That's great. We'll maybe come back to that once we've got the hard copies. And yes, we'll come back to that. Can I ask you, asked you a moment ago about DC Grady. DC Grady, in his inquiry statement, recalls a meeting with you on the 4th of May, which was the day the post-mortem was carried out.
Mm-hmm.
And I wondered whether you remembered having a discussion with DC Grady. He's obviously named as one of the people who was present in your provisional report.
And I think there was a briefing before the post-mortem. So we're sitting down in the room in the city mortuary where I was provided with a briefing paper. So I can't remember if that was his name, to be fair, but I'm assuming that's who it was. Yeah. So I presume both myself and Dr Behader would have sat down. We normally, before any sort of suspicious case, we normally sit down with the police and get as much information as we possibly can, which ideally is provided in a paper copy, and they normally talk through what they have so far.
At any point did he ask, or any of the gentlemen there ask if you could give a provisional view on whether the cause of death was due to a blunt force head injury?
Was this prior to the post-mortem?
Yes, as far as I'm aware, yes. He mentions that in his statement that there was a meeting at 12:40 on 4th of May.
Because that would have been prior to the post-mortem. I don't remember specifically being asked that, but I would imagine I would have said I couldn't comment without having actually undertaken the post-mortem.
All right, thank you. Let's go back to the provisional report, please, Perk 01444. And if we can go back to page 2, we were looking at the background history. And you've told us a little about that. And you've said that you summarised here what you consider to be the important elements that had been drawn to your attention. And then in paragraph 2 down there, after the 0715, so if we can turn on to the next page, you mentioned 7:15 hours, that's in the morning of the 3rd of May 2015. There were reports of a male in the area in possession of a large knife. Witnesses reported him kicking out and chasing cars. Police officers dispatched. He engaged with officers and a physical confrontation ensued, resulting in him being restrained to the ground, handcuffed, with leg restraints being applied. During the restraint, he became unresponsive and resuscitation was commenced. An ambulance was called and he was taken to A&E and later pronounced dead. And there's no mention in there of, at that stage, your initial report, of the use of CS spray or Pava spray or batons.
I don't know if that was in the initial briefing, but I was definitely made aware, if it was orally, that there was potential for batons to be involved and Pava and CS spray. And the reason I know that is because of the different actions I've taken during the post-mortem examination in terms of looking for subcutaneous hemorrhage around where handcuffs may have been applied, and also taking specific samples as we were going to try and get samples analysed for those things. So even though it's not mentioned, I presume that's probably because it's not in the briefing paper, or it's an oversight on my part, but I was certainly made aware that that was the case prior to the post-mortem examination.
Thank you. And then we see that you come on to external findings, and here you see the body was that of a dark brown skinned adult male of heavy build, measuring approximately 178 centimetres, 5'10" in height, and weighing 81 kilograms, 12 stone 10 pounds, BMI of 25.6. And were those measurements that you took prior to the post-mortem?
Yeah, they are provided to me by the mortuary technicians. They will do those standard measurements on all cases.
Right. And where you say heavy build, what did you mean by that?
Muscly built. He obviously wasn't overweight at all. He had a BMI of 25.6, but he was very muscly built. I probably should have used the term muscly rather than heavy built, to be fair.
So heavy is not a reference to his weight or his BMI,
No,
it's more
just his general
muscular.
size, muscular, yeah.
Right. And is this a visual description of the colour of his skin, dark, where you say dark brown?
Yeah, very much so.
Then in the next paragraph under external findings, I'd like to understand what you're talking about here. And you say within the right upper conjunctivi were at least 8 fine petechial hemorrhages, and in the lower right conjunctivi a collection of coarse and fine petechial hemorrhages. And obviously the chair can read this paragraph, but I wonder if you could explain, just in perhaps more simple language, what it was that you were noting in the area of the eyes.
In all of our cases, regardless of potential causes of death, we will always look very, very carefully for petechial hemorrhages. Petechial hemorrhages are tiny little dot hemorrhages that you often see in the kind of lower parts of the eye, and in the upper parts of the eye, in the mouth or behind the ears. And it tends to be in these are kind of mucosal membranes where the blood vessels are very kind of small and slight and reasonably easily damaged. And what happens is these tiny little blood vessels basically pop. So the hemorrhage or the blood that's within them escapes around, and you just see tiny little kind of dot hemorrhages. And we can see these for a variety of reasons, hence why we always look for them. In our forensic practice, kind of everything's a homicide until proven otherwise, so we want to absolutely categorically know that there's nothing that we're worried about with regards to those hemorrhages, because one of the main reasons can be asphyxia, or a lack of blood supply for various reasons can cause these little blood vessels to pop. But you can also see them in perfectly normal, natural reasons. You may all have, if you have had vomited for a period of time, you may actually have noticed yourself you get little hemorrhages sometimes, and that's basically because as you're vomiting, you're increasing the pressure in the blood vessels in your kind of face and head, and these blood vessels are so small and kind of slight, they just pop, and you can get lots of little dots even around your eyes if you vomit. You can also see them in the commonest way I see them is in people who have been resuscitated. So people who have had been in cardiac arrest, so have their hearts not pumping and their lungs are not working, and you see people having to basically pump on their chest with their hands. Because in the process of doing that, again, you're pushing blood at a reasonably high pressure up towards the brain, because that's the purpose of it. The purpose of it is to get blood to the brain, get oxygenated blood to the brain, so that the person will hopefully not have any degree of brain damage if you are successful in your resuscitation. So that's commonly how when we would see them as well. So they are just tiny little hemorrhages in different parts of the eyes. You can see them in the mouth, you can see them in behind the ear, that we see reasonably commonly in some situations, but they are a more worrying sign if we see them with the potential of asphyxia being a cause of death.
And what is asphyxia?
Asphyxia is a lack of oxygen. Its name is asphyxia, so it's a lack of oxygen to the brain. But there are lots of potential reasons for asphyxia. Kind of one example is kind of positional asphyxia. So if you can imagine, if you're sitting up kind of in a chair, your airway is fairly protected, you can breathe fairly easily. But if you're suddenly maybe turned upside down, heads on the ground with your kind of legs behind you, you can imagine that that's going to make it a bit more difficult for you to breathe, because your neck's in an odd situation. You may be covering your mouth, you may be covering your nose, your inner airways may be kind of obstructed, and that's a type of positional asphyxia. So it's a person getting into a position that will alter the oxygen kind of going to their brain, hence the word positional asphyxia. We have other types like mechanical asphyxia, and that is when you have something that's stopping you from breathing, be it maybe an object. For example, we see it unfortunately but reasonably frequently in kind of industrial type accidents, if people get stuck in machinery. So the machinery is kind of maybe pushed against their chest, so they can't breathe, they can't extend their chest, they can't get oxygen in. Which means the oxygen, if they can't oxygenate their tissues, the oxygen can't go to the brain, so you get a type of mechanical asphyxia. So there are different reasons, but ultimately it's a lack of oxygen going to the blood that can cause someone's death if it's for a prolonged period of time.
I'd like to explore these things with you in a little more detail, but I'm conscious that it's 11:30.
A convenient time to have a 20-minute break. Yes, Ms. Graham.
Thank you. Before the break, we were talking about asphyxia, and you'd given us a brief explanation about positional asphyxia and mechanical asphyxia. I wonder if you could just help people who are listening in today to understand how oxygen would normally flow through the body if someone's well. Mm-hmm. You've talked about how it can be interfered with through position or mechanical means, but I wonder if you could explain how it would normally work.
Okay. So when you breathe in air, so you breathe in oxygen, and that's taken in through your lungs. And there are tiny little blood vessels, little capillaries in the lungs that will take out that oxygen from the air and transfer it into your circulation, so into the blood vessels in your body. That will be taken to the heart, and then the heart's the pump that pumps the blood out to the rest of the body, so it gets the blood with the oxygen in it and nutrients to your other organs. So when the heart pumps, in every kind of heartbeat, you'll get a pulsing of the blood, which will go up the blood vessels going towards the brain, and will oxygenate the brain and give the brain its nutrients. So if you get any obstruction to that oxygen getting there, then the brain is not getting the required amount of oxygen, and the tissues will become hypoxic, which just means there's a lack of oxygen and will begin to kind of shut down and die off.
And in terms of positional asphyxia, what hindrance does that give to the normal flow of oxygen around the body?
So if you're in a particular position where you maybe can't breathe properly, so you can't get the oxygen from the air kind of into your mouth, going into your airways and into your lungs to be kind of transferred around the rest of the body, if there's something that's stopping that from happening, for example, if you're in a particular position where your airway is compromised because it's maybe the shape of your neck or the position of your neck is maybe kinked slightly, so the airways, the oxygen can't flow properly through because there's maybe a blockage because of the shape of your airways, or if your mouth's covered or your nostrils are covered and you're not able to take in the required oxygen. You can also, if you're in a particular position and your neck's at an odd position, you may be kinking the blood vessels that are taking blood up to the neck and bringing blood back from the neck as well, which is another mechanism of a positional asphyxia type pattern.
We heard evidence last year from an officer who described someone slumped in the back of a police car, and that position caused the person to have issues and positional asphyxiation. Would that be a sort of recognised way if someone is lying slumped and not breathing efficiently?
Potentially, yes. Often in those types of cases, there's also the problem of drugs being on board, which can affect how you manage your own airway and also put you into that sort of position because you're unaware. But yeah, that's a perfectly reasonable explanation, as if they're in a particular position that's affecting their airway, they could have had a degree of positional asphyxia.
Now, obviously, as part of the inquiry, we've been gathering in a lot of documents and witness statements, and I just want to ask you for your comment on this. One person has suggested that positional asphyxia is junk science. That's the phrase that's used. Do you have any comment about that?
I would completely disagree. There's a lot of literature out there about positional asphyxia. I've seen cases myself of positional asphyxia, and it makes perfect sense from a medical point of view as to why it may happen.
And is that the explanation that you've given today, this perfect sense that you talk about?
Yes.
Yeah. In terms of mechanical asphyxia, can you remind us what does that interfere with in terms of the normal flow of oxygen around the body?
It tends to be when there is something or an object stopping the normal breathing process. So typically maybe an object on the chest where when you breathe, if you take a breath in now, you can feel your rib cage expanding, and that's your ribs and the muscles in between there kind of relaxing and contracting. And that's the first part of the kind of breathing process. That has to happen for the oxygen then to be taken in to the rest of the system. So if you have something that's impinging that or stopping that from happening, i.e. if there's an object on your chest and you can't actually physically breathe, so you can't get the same breaths in, then you're not able to take the same amount of breath and amount of oxygen in that you would do normally, and that's kind of a classical mechanical asphyxia.
So something that prevents your chest or your rib cage expanding and contracting in the normal way.
Yes.
Right. Thank you. Now, before the break, I said that we would get WIT 00003 for you. This was the briefing note, just to let you have a quick look at that. And I think you should now have been given a copy of that. All right, sorry, it's at the front. And is that the briefing note that you were given prior to the post-mortem?
Yes, yes it is.
And you'll see it's 3 pages, and it prepares a history. It says at the beginning, to be updated by PERC. And then there's a medical history, and it details the circumstances, i.e. the locus of death and the circumstances of death. And there's 3 pages detailing those.
Yes.
And on the final page, around a third of the way down, it talks about the deceased engaged with the officers and a physical confrontation ensued. This resulted in the deceased being restrained to the ground. Handcuffed and leg restraints were applied.
Yes.
So certainly this briefing note did give you information about the use of handcuffs and leg restraints. And you said that you incorporated that into your examination in the post-mortem.
Yes.
And then the next paragraph after that talks about during the restraint to the ground he became unresponsive and CPR was commenced. So you were aware that CPR and resuscitation have been part of that process?
Yes.
But again, there was no mention there of baton or sprays at that time. And I think in your statement you've indicated that that would probably have come from a verbal or a discussion with PERC and the police officer before
Yes,
the post-mortem.
I was definitely aware of it.
That's lovely, thank you. I'd like to move back onto your provisional report, please. So if we can go back to that and have that on the screen. That's PERC 01444. And I think we were about to move on to page 3, if that's possible. So we'd gone through the initial process. We've come to the external findings, but if we stay on that page, please, just move further up. Thank you. So you've talked to us about the external findings. I had asked you about the conjunctive pedicule hemorrhages, and you gave us an explanation about that. And then do we see that you went on to the section on scars?
Yes.
And you have, you said previously that you were very detailed, so actually you've detailed 14 potential scars, and as part of your report, we're now moving on to page 4. And these, can we just stay there for a second? And then we see signs of medical intervention. We see that on the screen, and that's on page 4. And you've got 4 things here. Is this where you note things like injection sites and that type of thing? So your examination covers, as you said earlier, even very small things that you can see.
Yes.
On the body. And you'll see the first one on the back of the right hand, a needle puncture mark. This was associated with swelling of the hand.
Yes.
And that's through medical intervention.
Yes.
And how is it you decide that something is through medical intervention as opposed to some other cause?
The signs of medical intervention are normally fairly obvious, especially when it comes to needle puncture marks. There are specific sites that medics will use when trying to resuscitate patients and we're trying to take blood from them as well. So often we will see marks in the back of the hand as they've tried to cannulate, and often because it's being done in such a dynamic situation, they will puncture the veins, so there'll be a reasonable amount of bruising, or there'll be swelling associated with that. The crease of the elbows and the kind of front of the elbow are quite common places that medics will try and get access kind of during resuscitation, and the neck, places like this if they put in larger lines. So there are very, very specific places that I know as a medic, and having done emergency medicine in the past, as to where you need to look at, and they're very specific in how they actually look as well, as opposed to other injuries that we may see that are kind of specifically have occurred prior to the resuscitation.
All right. Can I ask you, before we look at the injuries, which is the next section on page 4, can you explain, you talk about head and neck and trunk and right arm, left arm, we'll go through those in a moment, but the introductory paragraphs on the external findings detailed the petechial hemorrhages, and I'm wondering if you can explain why there's not a separate section in the head and neck, or perhaps eyes, where you note those. Why are they at the preliminary part of this section?
Because they are one of the first things that we are looking for, and one of the first things that we're documenting, and they are documented in the external part. We're not looking at them specifically with regards to the injuries, so we don't differentiate them out. And occasionally on post-mortem reports, if they are very florid and there's lots of other things to notice in the eye, I will do a separate maybe eye examination, and I will document them separately. But in the vast majority of cases, they're included under the initial external examination when we're looking at eye colour and things like that.
So are they not viewed as injuries in terms of that section? Or
Yeah, they're not a specific injury. They're a response to something.
Right.
They're not actually a specific injury that's been sustained. Yeah, so they're not. Hence why they're not under injuries.
So they're viewed as a distinct aspect of your examination compared to actual injuries?
Yes. Yes.
And what would injuries be then?
So there are two different types of injuries. There are blunt force injuries, and there are sharp force injuries. Blunt force injuries are broken down into 3 different main types, from the kind of simplest to the more complex. So the kind of simplest blunt force injury, blunt force injuries are sustained from an impact of some sort. So something has come into contact with the skin, be it could be an object, it could be the ground, it could be a wall, it could be a fist, it could be a foot, but something solid has come into contact with the skin, and that makes it blunt force. So abrasions are the kind of simplest type of blunt force injury, and they are just basically scrapes or scratches. To all intents and purposes, that's the simple term for them, a scratch, where they're very, very superficial, so it's just the very, very top layer of the skin, the kind of epidermis, and that part of the skin is not very vascular. There's not a lot of blood vessels there, so abrasions, and you'll all have noticed if you've scratched yourself, it tends not to bleed, because it's so superficial. It's just kind of there at the very kind of tip of the skin surface. So that's the kind of most minor of blunt force injuries. Then you have bruises. So, everyone will have bruised themselves at some point. Again, another blunt force impact. So something has come into contact with the skin, and when it's pushed against the skin, the blood vessels that are underneath the surface of the skin burst. So this is kind of just slightly worse than abrasions. And because these blood vessels have ruptured, the blood has leaked out into the tissues that are underlying the skin, and that's why you see kind of redness or purpleness when you bruise yourself, that will go through various stages of colouring as it heals, and then just disappears and won't leave anything in its wake. Same to an abrasion, won't leave anything. It'll heal perfectly normal, shouldn't scar. And then the third type of blunt force injury are lacerations. So they are tears of the skin. So when something presses against the skin, it basically twists the skin and rips the skin apart. again, they can be different degrees of severity. You can have a very superficial laceration, which is just involving the top layer of the skin, right down to full thickness, where you're going through all of the layers of the skin, and potentially, if it's been a significant blunt force impact, you can damage underlying structures like bone. So potentially, if you had a common places on the scalp, because the skin is quite thin there and the bone is quite close to the surface. So if you have something hitting against the scalp, the skin tears. If the impact has been heavy enough, you can get a fracture of your skull. So it gives us a different way of interpreting how much force has been used in the impacts that have been sustained. So those are the 3 types of blunt force injuries. And then we have sharp force injuries, and they are sustained, as you would imagine, with a sharp object. So commonly with knives, we would see that a stab wound is a sharp force injury, and it is when an implement is used cleanly cuts through the tissues. So it's not this blunt force where there's kind of twisting and scraping. It clearly cuts through the tissues and anything else kind of underlying that, and the wounds look very different. With blunt force injuries, you can often have a combination. So in one blunt force injury, I may see abrasions, bruises and lacerations, because they all have a similar mechanism. Whereas it would be rare to see a blunt force injury around a sharp force injury. You tend to see kind of relatively nicely cut skin, a clean cut wound, rather than a very irregular wound that you would get when it's blunt force. So those are the kind of 2 big kind of categories that we differentiate when we're describing wounds.
And you distinguish between those categories when you're doing your examination?
We do, as much as we possibly can. There are occasionally wounds where it's very difficult to differentiate, and in those cases we'll be very descriptive, rather than specifically saying it's a laceration or even occasionally with kind of abrasions and bruises, it can be difficult to differentiate. But as much as we possibly can, absolutely, we will state exactly what kind of injury each thing is that we're finding.
And both these categories, blunt force injury and sharp force injury, they use the word force in there, and you suggested these assist you in interpreting the force. To assist the chair, I'm wondering if you can help him understand how the different types of injury assist in interpreting the level of force used.
As I said, abrasion and bruising abrasion specifically is kind of at the other level of kind of very, very minor force. Bruising, underlying bruises, you can see fractures, you can see injury to underlying tissues. And if that's the case, then we are looking at a higher degree of force. So kind of force is we tend to measure it as kind of mild, moderate to severe on a scale. And obviously mild being the least, severe being the most. And if you have, for example, someone who has a large laceration on their head with an underlying skull fracture, then I would be putting that up towards severe force has been used, because the skull's quite a thick bone, and it takes a reasonable amount of force. Again, with the caveat that it depends on what weapon has been used. It would be less force would be required if someone is using a heavy hammer to fracture the skull, as opposed to something that's lighter. So there's lots of caveats when we're talking about force, but to all intents and purposes, it really depends on what's been damaged in terms of bones and in terms of organs as to where we would put the degree of force underlying. And the main thing we use it for, to be fair, is sharp force injuries. So if someone's been stabbed and they have, say, someone's been stabbed through the chest and it's gone directly through their intercostal muscle, which is the little muscle between the ribs, and it's gone through the heart. It doesn't actually require a huge amount of force to do that. The most difficult thing to get through is probably the skin. That's the kind of firmest, because you're just going through muscle and soft tissue. And again with the caveat, it'll depend on how sharp is the blade, what type of blade's being used. But if you've got someone who has been stabbed and they've gone directly through the sternum and then managed to penetrate the heart, then that's severe force, because the sternum is a big, thick, very, very hard bone, and to get a knife all the way through it would be really, really difficult. So severe force has been used. So those are kind of the parameters we use, and it very much depends on what's been damaged and what's been injured underlying the external injury that you're describing.
We'll come on to this later, but we'll hear evidence about a possible fracture to the first left rib.
Mm-hmm.
Can you assist the chair in understanding the level of force that would be required to fracture that rib?
It's much more difficult to fracture that rib than it does any other rib, because it's hidden way behind the clavicle, kind of in the shoulder girdle. There's lots of muscles around there. Fracturing of the actual rib cage is not actually that difficult, and if there were rib fractures involved, I'd be kind of looking kind of between mild to moderate force normally. But because this rib is really well hidden, we very, very rarely see fractures of these ribs. Then I would suggest that kind of more force would be required, so it would be kind of moderate going up towards the severe kind of end of the spectrum, even though it is a rib, just because of where it is and how much it's hidden and protected.
Thank you. But if a rib is fractured during if a rib is fractured in the rib cage, say 4 to 6, that would require less force to fracture a rib there.
Yes.
Right, thank you. And right, just to return then to the external findings before we move on to the specific injuries. We were talking about the petechial hemorrhages, and you said these aren't categorised as injuries as such. So can you provide an explanation of what can cause these petechial hemorrhages? And I'm interested in particular in relation to Mr. Bio.
Yeah. So there are several reasons with Mr. Bio. We have to consider his position. We have to consider, with the information that we were given, in how he was restrained, in terms of him being face down, kind of chest down, that there could have been a degree of positional asphyxia as to how he was. So I think that's one of the things we have to consider. We also have to consider the mechanical side of things as well, and I spoke about pressure being on the chest, and we were given information about pressure being put on his back with kind of knees or police officers on his back, so that could have impeded his breathing. And the third thing to consider is that he was resuscitated quite extensively, and as I had said previously, the commonest cause that I see for petechial hemorrhages is resuscitation. So that's another kind of third factor as well. So I think all of these things have to be considered.
So for the chair, when he comes to consider the evidence that he's heard about the circumstances, you would recommend that he consider the position that Mr. Bio was in?
Yes.
And would that be the position shortly prior to a significant event, like he's unconscious or not breathing, or is it just generally his position during the whole restraint?
Well, generally his position, but more so in the lead up to him having a cardiac arrest, because something's obviously happened in that period, in that time scale. So that would be the important part to look at, yes.
And you mentioned him being prone or chest down. Again, can you explain to the chair quite simply how that impedes the breathing?
So if you are prone or kind of lying down kind of on your front with your neck kind of slightly extended, it's much more difficult to breathe properly. There could also be a degree of the mouth or nose being obstructed if you're lying face down potentially against a surface. So it's the air's not able to get in the way it normally would do.
And if you're face down, but your face is not directly down, but maybe to the side, does that make it better, easier?
Again, if your neck slightly altered in position as well, and your throat's down, your top of your chest is down, can all impede the oxygen actually being taken in the first place.
So if your head's to the side, can that also impede?
It could do, yes, because you're altering how your airway's kind of moving in your neck.
And if you're on your side, could that cause any issues with breathing in oxygen?
It would depend on how the rest of your body is. If you were kind of lying on your side, then potentially not.
Okay. We've heard some evidence about perhaps Mr. Bio being on his back.
Mm-hmm.
So in terms of positional asphyxia, would there be any issue if someone's lying on the pavement on their back? Would that cause any difficulty?
It shouldn't do if his airway is protected. It shouldn't do. If you're lying on your back, you should be able to breathe and get an air in reasonably well if there's nothing kind of obstructing.
It may have been suggested that that would prevent the back of your body and your lungs from expanding slightly, even if you are on your back.
If you're just lying on your back and there's nobody, I mean, if you had something on you or someone on you, then potentially. But if you are just lying on your back with nobody altering what you're doing or altering your breathing, I don't see how that would impair your airway.
So it would depend on the particular circumstances, whatever the chair
Yes,
considers.
yeah.
Mm. And then the second element you talked there about mechanical pressure on chest or back could impede your breathing. Can you give the chair a little bit more assistance in understanding that factor and the importance of that?
So anything that is pressing down on the chest, either front or on the back, because your rib cage goes all the way around. It's not just at the front, it's kind of a cage, if you like. So if there's something on your back pressing against your rib cage or on your front, then you're not able to breathe, you're not able to expand your lungs the way you would normally, so you're not able to take in oxygen the way you would normally, and that's hence the mechanical, because there's an object of some sort impeding you from being able to breathe properly.
What sort of things could be that object that would cause that restriction in the expansion of the lungs?
I mean, anything that's heavy on the chest. I mean, in this case, reports of kind of people kneeling on the chest, or a person even just holding down, not necessarily even being on. If you're kind of on your front and someone's holding you down to restrain, then it is going to impede you from being able to breathe. Similar if you were the other way and they were holding you down kind of at the chest area, it would impede you being able to expand your lungs.
So could that be weight being placed on?
Anything that causes a weight to press against the chest or the back, be it an object, be it someone, be it potentially the ground, if there's someone, or if there's something at the other side.
Or pressure being applied.
Yeah.
And is there any way to assess that level of weight, or in terms of pathologically, is there any way for you to assess a sort of significant compression or?
It's really difficult. I mean, again, we can look at external findings, so we can look at bruising, we can look at abrasions, we can look at laceration, because again, anything that's on is potentially a blunt object, so we can look at external injuries. We can look internally, so we can look at any bruising in the subcutaneous tissues kind of underlying the back or on the chest. We can look for fractures of the ribs, we can look for damage to underlying structures, and we look for all of that to see what there is to support a particular scenario.
And in this particular case, was there any significant signs that you noticed in your examination that were indicative of weight being applied or pressure being applied?
There wasn't anything that was categorically indicative. I'd have to look at my notes, but we looked at the back, and there was some subcutaneous hemorrhage underlying the skin of the back. So that suggested kind of blunt force had been applied to that. And I can't categorically say what that form of blunt force took place as, but if it's postulated to me, could this be in keeping with someone pressing down, then yes, it could.
We'll come on to the individual injuries in a moment. Thank you. Let's move on the report that we have here. Again, this is your preliminary initial report, and we see that on the injuries section, so if we can move down, it says a provisional description of the injuries is being described prior to receipt of the post-mortem photographs. Tell us why that's there.
Normally, when I do my provisional report, I prefer to do it with the post-mortem photos. So normally I correlate my description that I've done in the post-mortem room with my post-mortem photos. Here I was asked to provide my provisional report as quickly as I possibly could. And for that reason, I hadn't access to the post-mortem photos to be able to correlate. So that's why I've put the caveat to make sure it's clear to the reader that this has come from my descriptions in the post-mortem room that would have been scribed by Dr Behader, but I hadn't had the opportunity to compare that to the photographs, because sometimes I may change a measurement or something if I look at a scaled photo and think, oh, I've maybe underestimated that. So just little bits and pieces. So that would be my normal practice in a suspicious case, but because I was asked to do this as quickly as possible, I didn't have that opportunity.
Who asked you to do it as quickly as possible?
The Procurator Fiscal.
Thank you. So let's move on to head and neck. Now you have 10 injuries noted here. We can only see one page at the moment, which is 1 to 4. And the first one relates to the forehead, the second to the eyebrow, and then I think after that they all relate to the mouth area. Let's look at the forehead first of all, if we may. What is the first injury that you've noted there?
So over the left forehead, its upper end 1 centimetre in front of the hairline, and inner end 3 centimetre to the left of the midline, so kind of over the front of the left side of the head, an irregular abrasion measuring 3.5 centimetres across by 3.5 centimetres up down. So an abrasion being, as I said, the kind of simplest, a scratch, but often I'll describe abrasions depending on how I think they may have been caused, i.e. you can get a scratch abrasion where it's obviously something has scratched along the skin, but in this case it was irregular just because it looked a little bit ragged, so that's why I've given that description, but it's still, to all intents and purposes, it's a scrape across the front of the forehead.
Before we go through all of the details, can I just come away from this for a second? You've very helpfully prepared a glossary of all the terms that you're using, haven't you? Can we look at WIT 00041? You may have a hard copy of this. And this is to assist the chair when he comes to reflect on your evidence and your report. And does this contain a number of definitions of the words, the language that you'll use? Thank you. Let's go back to page 4. So we were just talking about the forehead, the first injury that you've noted on head and neck. Can you explain how an irregular abrasion, such as the one we see here, is caused on the skin?
So it's a blunt force injury, so it's impact with something blunt. Could be an object, could be the ground. So something has come into contact with the skin and basically scraped across the skin.
So if someone was face down or with their head to one side, is that the type of contact? Yeah. Or if someone was struck with a baton, could it be that type of contact?
That would be unusual. That would tend to be bruising with a laceration and potentially a fracture underneath as well. But abrasions are more scrapes. They're more in keeping with kind of contact with an irregular surface like the ground.
All right, thank you. And then we look at the second injury. What do you note there?
So 0.5 centimetre in front of the first injury, directly above the outer half of the left eyebrow, another abrasion 3 centimetres by 2 centimetres.
And can you point to your own eyebrow
So
to show us?
just be above the kind of middle
Same
part.
sort of area you were describing before. And you've described that as an abrasion. Is that, you don't use the word irregular there, does that make a difference to the possible causes?
And not in particular. Most abrasions will just be described as abrasions unless there's a difference. As I say, I use scratch abrasions sometimes, but it doesn't correlate to anything else specifically.
And then you move on to the remaining injuries which relate to the mouth. And I wonder if you could go through these injuries and explain to us what you found on your examination.
So within the upper mouth, at the border of the upper lip and the mucosa, so if you kind of just turn your upper lip inside out, your lip ends, and you get the kind of darker kind of fluidy bit of your mouth, and that's your mouth mucosa. And there was a very superficial, so as I explained previously, just the surface of the mucosa. It means it's very, very superficial. It hasn't gone further through other layers of the tissue. And this is a laceration which was S-shaped at 1.2 centimetres. So S, just to give you an idea as to how it looked on the mucosa, a laceration being a blunt force injury. So something has come into contact with that mucosa and caused a twisting for it to tear very, very superficially.
And when you say something has come into contact, can you help us understand what that could be?
Yeah, it could be blows with something, with an object. It could be with the ground. It could be related to his tooth. We often see if people have injuries to their mouth, if they've kind of bitten down, sometimes they bite through their mucosa of the inner part of their mouth, and it can cause a small laceration. It could be related to medical intervention. We often see if people have had quite extensive resuscitation and been intubated, which was the case here. Intubation is where the medics or the ambulance personnel have to put a tube into the mouth in order to help with breathing. So you can sometimes see injuries to the mouth because of that. So there's a number of reasons that these could have happened.
And for the chair, is there anything he could look for which would assist him in deciding which was the possible of all these causes?
Not in particular. To be fair, I think if you take it in the context with the other injuries, and there's quite a few injuries affecting the mouth, as number 4 in the right upper lip, there's up to 7 superficial lacerations. So again, 7 kind of very closely orientated little kind of tears in the skin, the longest being about 1 centimetre. So when you start to see lots of injuries in the mouth, it makes me less inclined to think it's because of resuscitation, and more inclined to say that it's because of blunt force trauma to that, rather than from being intubation being the issue. So you can't say for definite, but it kind of pulls me away from that and towards is it blunt force trauma? Have they had blows to the mouth? Have they had, with an implement, fists? Have they come into contact with the ground or other kind of blunt force area?
And you've said you would move away from medical intervention or intubation, as you've said. What are the specific factors that cause you to move away from that?
I think because there's so much of it. I see a lot of injuries from medical intervention, so this is my own practice and my own experience, and in those cases I don't tend to see as much injury as what I kind of saw in this case. So that's what would make me think at the time we were looking more blunt force than actual medical intervention. So it's very much experience based, and I've seen thousands of cases of people who have been intubated and been managed by paramedics and by hospital staff, and you don't tend to see them with this many injuries in terms of those being sustained while a tube's been put down the throat.
Mm. And you've mentioned that one of the possible causes could be contact with the ground. In what way would contact with the ground cause these types of injuries?
If the face is against the ground, against a hard surface and kind of moving, it basically pulls at the skin and can tear the skin. So that is a possibility.
Now, we've also heard evidence last year, not simply about the medical intervention in the hospital, the intubation, that type of thing, but we also heard evidence about something called a one-way valve face shield.
Okay.
And that officers had initially attempted to use this shield at the scene, but they'd experienced difficulties in using that. And let me just read out some of the evidence that it'll be a matter for the chair,
Mm-hmm.
but read out some of the evidence that we've heard about this. This was on the 21st of June last year, that an officer had taken out his valve, one-way valve. He was trying to get the face valve into Mr. Bio's mouth, but his teeth were gritted shut. So I tried my best by putting my fingers in and pulling it open. That probably accounts for quite a lot of the scratches and what you have around about the boy's gums, and I couldn't get it to go in. I'd done the best we could, and then another officer had tried to get a couple of breaths in, but it was leaking around the sides, and then he was getting contaminated. So his teeth were gritted shut. I couldn't get the valve to go in. He was trying, and he was putting his fingers in and trying to pull down his jaw and separate his teeth and get between his teeth. So that's a description that's been given by a witness. And I wonder if you could comment on that as a possible cause for any of these injuries?
It sounds plausible if they've had difficulty and if they've had hands in the mouth moving around with nails and things like that and pulling, because a blunt force is tearing. So potentially if there's movement of the head at the same time as they're doing things inside the mouth, I can't see why that couldn't potentially be a cause of causing such injuries within the mouth.
So there's the contact with the ground, possible medical intervention which you're less inclined towards, or this possible use of the one-way valve face shield. They would both be consistent, would they? With
I would say
the type
so.
of
Yeah,
injuries?
given what they've described that they've done, that would be consistent with causing at least some of these injuries.
As would contact with the ground.
Yes.
Thank you. And is there anything between those two possible causes which would distinguish them, which the chair could look out for when he's considering the evidence?
I think because a lot of the findings are within the mouth, there's not a lot kind of around the mouth or any kind of, I suppose, visible part that you would see if someone was just standing. So in terms of being on the ground, the mechanism to get problems internally would probably mean that the lips would have to be squashed against the ground to a certain degree, and the mouth would have to be kind of open slightly in order to expose the kind of inner part, which would be a bit more difficult to do but not out with the realms of possibility. So if what they're describing is actually putting hands into his mouth, pulling and things like that, and with great difficulty, then that's probably more of a reasonable explanation as to what you're seeing internally.
So an important factor, the actual location of these mouth injuries that you've noticed.
Yeah.
And you've detailed those in this section of your report.
Yes.
Thank you. And then if we can move on to the trunk, please. Sorry, I should have asked you one last question in relation to the head and the face. Did you see any injuries in your examination that may be consistent with a slap to the face?
So all of the injuries described are predominantly lacerations, which wouldn't be caused by a slap. A slap to the face wouldn't necessarily leave an injury, to be fair, but a slap to the face would tend to cause bruising, and quite extensive bruising if you've got the whole kind of palm of the hand. So there's certainly nothing specific that I saw that would relate to that.
And is there anything noted in this section that would assist the chair in assessing the level of force used and required to cause any of these injuries?
Everything is down at the minor end here. They're kind of superficial lacerations, there's tears, there's no underlying injury to the facial bones, which we'll come on to later. So there's nothing to suggest significant force has been required to sustain any of these injuries.
Thank you. Let's move now on to the trunk. And you have one injury noted here. And could you tell the chair what this is?
Over the right mid-chest, from the midline, it's upper end 8 centimetres below the clavicular head. So your clavicle is just your bone that kind of sticks out at the top of the chest here. So kind of just slightly further on down. There's patchy irregular abrasion, 8 centimetres up down by 5 centimetres across, comprising numerous intermittent abrasions, the largest 1.5 centimetres by 0.1, the smallest 0.1. So this is just a reasonable sized area of scratches. That the intermittent tends to be seen when something is scraping along something, so you get a scratch, nothing, a scratch, nothing, and we do tend to see that if in scratch abrasions, or more specifically in people who have been on the ground and maybe moved across the ground, their skin has moved across, so the irregularity of the ground surface has scratched, and then they come to a part of the ground that's not against the skin, and then come to another part, so you get a scratch, a space, a scratch, a space, and that's kind of what was here.
And was the injury that you saw in the trunk consistent with that type of injury where someone's been on the ground and their skin has moved along?
Yes.
And can that occur when someone's clothed?
It can do, yes.
So if someone had even just a t-shirt on, is that the type of thing?
You might see some dirt on the t-shirt, or you might see an injury to the t-shirt, but yeah, no, you can get such injuries through clothing.
Thank you. And is there any other possible cause of that type of injury in that location other than what you've described about moving along across the ground?
Nothing specifically. I mean, at the end of the day, it's a scratch, abrasion. It's at the kind of minor end of the blunt force injuries, and blunt force injuries, as I've said, can be caused by a number of different things. It's not specific. But just the pattern of this would be more in keeping with him being on the ground and it occurring secondary to the ground. Now, this is the only injury that you've noted on the trunk. Can I be clear, what area do you mean when you say the trunk? The trunk is from the neck to the pelvis, front and back. Right. And so, were there no other injuries that you noted? No. No injuries to the left side of the chest? No. The caveat with that is that with people with dark skin, it can be really difficult to see injuries, specifically bruises. Scrapes are a bit easier, and that's one of the reasons that we have to look internally. We have to look underneath the skin to make sure that there's nothing that we're missing, because it can be notoriously difficult to, because of the colour of the skin, to be absolutely sure that that is definitely a bruise and it's not just the contour or colour of the skin. And is that something that you bore in mind when you were carrying out your examination? And we mentioned earlier, and we will come back to the left first rib,
Is that part of the trunk that you're talking about, or is it a different area?
It's an internal examination of the head, well, chest. It would be an internal examination of the chest. It wouldn't be
Not
taken
part of
into
this.
account with the external examination of the trunk, no.
But were there any injuries that you noticed in the vicinity of where the left first rib would be? Would that be noted in the trunk area?
The external examination, it would be noted in the trunk area, and certainly on the skin there was nothing obvious.
So over, around, in the vicinity of that left first rib, nothing obvious on the actual skin externally?
Yes.
And were you looking in that area as part of your examination of the trunk?
Yes.
Thank you. Let's move on to the next section, right arm. So again, one injury noted here. Tell us about this injury.
So over the back of the hand, just proximal to the knuckle of the little finger, so just in front or below the knuckle of the little finger, there was a very superficial flapped laceration measuring 0.5 centimetre by 0.5 centimetres. So this is a laceration, so there's been tearing of the skin that's, as I've described, it's superficial, so just the top layer of the skin. But flapped is when you still have the skin there. Often in lacerations, you just get a splitting of the skin, so you just see an injury. Occasionally, when they're flapped, it just means that it shows you the direction of the force that's come onto the superficial part of the skin, and it's kind of almost undercut the skin and leaves the flap of the skin. So if you popped it back down again, it would kind of go back into its normal position. Whereas the vast majority of lacerations tend to just be like a mark through the skin directly, and the skin opens up. But occasionally you do get these flapped areas, which just shows you the direction that the injuries kind of happened.
Looking at that injury, what are the possible causes of that abrasion, the flapped laceration, sorry?
Potentially has been when he's been on the ground, and if the finger's gone against the surface of the ground. Potentially if he has, we often see injuries on the back of the hands in a defensive type pattern. If someone's put their hands up to defend themselves and an impact's been sustained to the back of the hand, we often see bruises and things in those sorts of scenarios, but that's something that we always think of when we have any sort of injuries on the kind of upper limb as a potential defensive type injury. So it could be a number of scenarios.
You've mentioned defensive injuries or putting someone's hands up. Can you explain to those listening what a defensive injury is?
These are the types of injuries we see when someone is basically trying to protect themselves. Often it's in the cases of people who are being attacked with a sharp weapon, and they'll put your kind of human nature is to protect your face, kind of protect your kind of upper part of your body. So people will often put their hands up either backwards or kind of forwards, and we can often see injuries to the palms, to the backs of the hands, and often the backs of the arms as well. And in terms of blunt force injury, if an assailant is using a blunt force implement and someone will automatically try and protect their head, they will put arms up. You can often see bruises to the front or the back of the hands and arms, and lacerations as well if a significant amount of force has been used.
So in terms of the force used, you've said this is a laceration. Can you give an indication of the nature of the force used here?
It would just be very mild because it's a very superficial laceration. It's just a tiny little area, so I don't think it would have taken much for that to happen. And it looks as if something's come across the skin, the way it's flapped. And I've said it's kind of flapped to the left, which means the way it's kind of been cut across. The flap opens up like this, so something's just come along very superficially under the surface of the skin to cause that injury, but it wouldn't have required a great deal of force.
And if the chair is considering evidence that he's heard about the nature of the the events at Hayfield Road, the restraint, Mr. Bile being on the ground, is there anything in particular about this injury that would assist the chair in determining what is the possible cause of this?
I think it's more likely to have happened on the ground because that's all you really have. You've only got that. We don't have any other injuries to the hand. We don't have any other bruising to the hand. And normally if someone has put their hands up to defend themselves, the bruising would be the mainstay of what you would see. So I think it's probably more likely that it's maybe happened when he's been on the ground and he's just come in contact with an irregular surface on the ground, especially with the flapping of it as well, which would make that more likely, I think.
So no bruising is an important factor in determining the possible cause. And could it be consistent with a punch having been thrown at some point?
With him having thrown a punch, potentially. Mm-hmm. If he's come into contact with a blunt area, then that would potentially be a cause.
And are there any particular factors that make that a less likely option or a more likely?
Again, lack of bruising, as we often see with those sorts of scenarios with the punches, you often see bruising associated with that. And you can also see fractures underlying that as well if the punch is thrown with hard enough thought. So that would probably make it less likely that, again, there's not the other factors that are there, but it's a possibility.
Mm-hmm. And what about the application of handcuffs during a struggle? Could that potentially be a cause for an injury to the hand?
No, absolutely, because especially if it's been done in a struggle, potentially if the handcuffs come up towards the knuckle and kind of taken off, because they can be quite sharp in areas, handcuffs. So that's a potential mechanism of it being caused as well.
So possibly the ground, contact with the ground, possibly contact with the metal handcuffs?
Yes.
Thank you. And again, is there anything particular about the nature of this injury for the chair to look out for in terms of deciding which of those possibilities is maybe more likely?
I think the handcuffs probably more plausible than some of the other scenarios apart from being on the ground, because you probably be less likely to see extensive bruising if there's just been if it's kind of passed on and taken the skin from the surface. So it probably would be nearer the top of my list if I had to list them in order of what I think's more likely. But again, in these sorts of scenarios, it's impossible to be definitive as to exactly what's caused it.
And obviously, if you're looking at handcuffs, they're generally they're metal, they're cleaner, whereas the ground you may expect grit or dirt or whatever.
Potentially.
If it was the ground, would you expect to see signs of grit or dirt or anything in the injury?
It's a possibility. Again, it depends on what the contact has been with and how long it's been for. So that is a possibility. If there's no grit or even associated abrasion, that's often what you see with them coming into contact with the ground. You see more scrapes than lacerations. So that maybe would make it less likely as well.
And if you had found scrapes or abrasions or grit or dirt, is that something you would have noted in relation to that specific injury?
If I'd have found it, the problem is that from a grit and dirt point of view, he's obviously gone through various medical procedures and in hospital. So there's a possibility that anything like that had been cleaned off. So just because it's not there doesn't necessarily mean that it hasn't been there. But certainly when we do our external examination, we do a dirty external examination, if you like, initially. And then clean. The body's thoroughly cleaned before we have a much more detailed look. So I would always note things like dirt staining, grit, if there had been anything like that.
Would that include grass staining?
Yeah,
or anything like that?
Any staining on the body at all. If it's there, it would be noted in the external examination and should be photographed, because we always take photographs before the body's cleaned as well. And then we would clean the body thoroughly before we then look for our injuries.
So if there had been anything like that, that's something you would have noted?
Yes.
Thank you. And let's move on to the next area, which is the left arm. And there are 7 items here, so they move on to the next page. So it's injuries 13 up to 19, and I would like to take you through those injuries and ask you to describe the different injuries that you discovered on his left arm, please.
So over the back of the lower half of the upper arm. So
Can you show us where that area is?
The upper arm is from your kind of elbow to your shoulder, and your forearm is from your elbow kind of down to your wrist. So this is an anatomical position. This is the kind of front of the arm, and this is the back of the arm, is how you kind of would stand anatomically. So over the back of would be the back of the arm, lower half of the other upper arm would be kind of just above the elbow. And there's an irregular abrasion measuring 8 centimetres up down by 5 centimetres across, so quite an extensive sized kind of scrape over the back of the arm, which again, it's blunt force, could have been when he's on the ground and he's kind of scraped against the ground as a potential mechanism.
So that would be contact with the back of his left arm with the ground?
Yes.
So if he had been on his left side, for example, is that the type of contact that...
Yes.
And moving?
Yeah.
Part of the moving. And you've described that injury or those injuries as abrasions.
Yes.
So again, in terms of the level of force, are you able to give any assistance?
Again, they're just simple scrapes to the superficial part of the skin, so just the kind of mildest force.
And if someone was wearing a T-shirt with short sleeves, was it in the area that would be beneath the sleeve of the T-shirt?
Yes.
So any contact would be skin to ground rather than through clothing?
Yes.
And would that make any difference to the nature of that injury?
It can make it a bit more pronounced if you don't have the kind of protective barrier of the clothes in between. It can make it just a bit more raw looking, potentially.
And is that something you would note in your examination?
I would describe it if there was any other different appearance that was kind of out with what I normally would do, and I haven't done.
You haven't noted. And then moving on to other areas of the left arm.
So over the ulnar aspect of the elbow, so the hand or the arm is split into kind of different sections depending on what nerves supply the different sections. And the ulnar part is the kind of inner part with the kind of little finger, ring finger, and the half of the middle finger. So if you draw a kind of a line from that middle finger up the centre of your arm, everything on kind of this side is ulnar and everything on this side is radial. So it's just a way of us of describing anatomically where things are, where we know exactly, if we're asked, we can go back and say it's just here. So over the ulnar aspect of the elbow is just on the inner part of the elbow here. And again, it's another irregular abrasion, 4 centimetres by 2.5 centimetres, so a superficial scrape that would be consistent with him being sustained while he was on the ground and going against a rough surface.
Are there any other potential causes for the type of injury that you're describing to the left arm?
Again, it's blunt force, so impact with an irregular object is always a possibility, and impossible to kind of differentiate.
And then the next injury, number 15, over the front of the middle third of the forearm.
So this is the front of the arm. We all often separate into kind of middle third, lower third and upper third, just again to differentiate so we know exactly where the injuries are. And this is on the middle part of the forearm, another irregular abrasion, 4 centimetres by 2.5 centimetres.
And how would that abrasion be caused on that aspect of the arm?
Again, I can just be scraping against, that arm's easily turned over, so just because it's on the front doesn't necessarily mean that the front hasn't been in contact with the the ground. So it would be similar to the other ones on the arm.
And still superficial
Yes.
level of force. Then injury 16, tell us about this injury on the forearm.
Around the lower third of the forearm, it's distal end 5 centimetres from the wrist. So lower third is the area that's just above the wrist, probably for about maybe 7 or 8 centimetres. Its distal end 5 centimetres from the wrist tells me that its lower end, so its area that's closer to the fingers, is about 5 centimetres from the wrist. And there's this band of brown discoloration extending over the back of the arm and measuring 1.9 centimetres in maximum width. So there's a width being sort of 5 centimetres up to about here, and then for almost 2 centimetres there's this band that's going right round the back of the forearm.
What would that be consistent with?
That we're thinking about the handcuffs at that point. That's kind of typical for a handcuff type injury. Again, because of the dark colour of the skin, it's what we would normally see would be bruising. But because of the dark colour of the skin, what we're seeing is bruising, but having to describe it as a dark band because the kind of prominent blue or red colour is not kind of able to be seen on the skin. But we're thinking handcuff injury for that.
So in terms of the location and the nature of the injury and the dimensions that you've given, is that consistent with the application of a handcuff
Yes.
to that area with struggling or moving in
Yes.
relation to that?
Yeah, exactly.
I wonder if that would be an
We'll
appropriate...
stop for lunch then. 2 o'clock.